when we get excited with pain management, we get excited because there are a lot of machines and a lot of things that we can do that make us feel that we are very clever. You know, like, you know, I can block this nerve, and now we have so many things to help us to image. Last time we have to ask the radiology department to let us use their machine, their C-arm, or we have to go and do with the radiologist the CT scan to locate where we want to put our needles. But now with the ultrasound machine, anybody can do it in the clinic also. You don't need a hospital, you don't need a full operating theater. We can do a lot of procedures in the clinic. So it's very attractive because it looks very simple, and we think we do no harm because we can see where we are, right? So we think that it's okay, we can do this. I think that it's okay to do procedures, but you must always remember again the patient. So first, assessment. So I'm very happy that one of the presenters talked about assessment. You need to assess the patient. What kind of pain is this person having? Is it acute or chronic? So go back to RAT, go back to your recognize, assess and treat. And I'm very happy that in Vietnam, a lot of people are running the EPM, the Essential Pain Management training. If you haven't had the EPM training, please ask the organizers of this conference where you can get this training. It's very basic training for you to understand about pain, and you need to know how to recognize, how to assess, and then how to treat. So don't just jump to treatment straight away just because a person comes to you with pain. First, must assess. And when you assess, you have to decide acute or chronic pain, cancer or non-cancer pain, and nociceptive or neuropathic pain, okay? Because your treatment really depends on your pain diagnosis. So acute pain, we can do a lot of things for the patient. And when the injury heals, when the wounds heal, when your surgical wound has already healed and the original pathology is better, the patient will get better. But you help them to get through the painful part. When there's a lot of inflammation going on, you help them get through that by doing your interventions and giving a lot of medication. But the aim is to get this person back to their normal life. So similarly, when you have cancer, patient with cancer, we do the interventions to make them comfortable so that they can interact with their family. They can do things like what was shown, can have a party, can listen to jazz, you know, whatever music, whatever things they want to do before, because they know that the end of life is coming soon. And the family also will be happy because you allow them to enjoy, to be able to live the limited rest of their days, you know, in comfort, okay? So that is for cancer pain. But for chronic non-cancer pain, which is actually the majority of a lot of conditions which were presented today, the patient lives for a long time. And our goal is not to give pain relief, but to improve their function, to make them go back to work, to make them be able to go out with their family to enjoy the cinema or to go to social functions, okay? To make them be able to earn money for their family and look after their family, to make them not sit in the room and just, you know, be so upset because they're having pain all the time. When we do interventions, we can take away the pain. Yes, we take away the pain. But we must remember, are we taking away the pain for a short time or for long term? So I heard just now there was also a presentation talking about short-term benefit versus long-term benefit. So if a person has chronic non-cancer pain, they're not going to die, they're going to live for many years. We must always think about how do we give them the long-term benefit. So when we give them medications, or we do interventions, or we do ultrasound, and we do, all the modalities, how do we maintain the for in translation? Oh, you cannot. So you want me to stop? Okay. Okay, just a little bit more. Sorry, I talked for too long. Sorry. But we must remember, you just have to remember, we are looking at short term versus long term. Which patient you need to give short term treatment, which patient you need to give long term treatment. And when you treat patient, it's very nice if you can get money, if you can get satisfaction. Yes, it's very nice. But we must remember, it's the patient who has to live with the pain. So in the end, what do we have to do? We have to make the patient understand what is happening to them. We must let the patient understand what they have to do to be able to maintain, to be able to gain back their function. So exercise, somebody talked about exercise just now. As part, patient education and exercise as part of your treatment. Remember, talking to the patient is part of your treatment, not just doing things for the patient. So just to end, one thing that we have a saying, if you have a hammer, everything looks like a nail. Okay, so I don't know how you translate that into Vietnamese, but I'm sure you can translate it into Vietnamese. So once we buy our machine, we want to use it for everybody, but we have to take a step back and think, is it really good for this person if this person has a long-term problem? Okay, so that's all I have to say. I want to congratulate Professor Ho and the Ho Chi Minh Pain Society, as well as the VASP, Vietnam Association for the Study of Pain, for organizing this conference. I see all of you are very engaged, very happy to be here. And I see there's a lot of progress in Vietnam, but I also am happy to tell you that IASP, International Association for the Study of Pain, is happy. We are willing and able and happy to support you in terms of training, in terms of education, and we hope that we want to promote multidisciplinary, interdisciplinary, using pain management using both pharmacological and non-pharmacological intervention and non-intervention, and a patient's own self-management techniques. So thank you very much. Thank you, Professor Hu, for inviting me.